On behalf of the USC Spine Center, my name is Jeff Wang. This is David Cheng. We're part of the USC Spine Center, and we'd like to welcome you to our monthly webinar. We'll go ahead and get started, and people may join the first part. And let me just share my screen. For anyone who's been here before, you know that we put on this monthly webinar series. We always like to start off with a bit of an introduction to the USC Spine Center. For those of you who have signed on before, I apologize if there's some redundancy here, but we wanted to just give everyone a little flavor of what we're doing here at USC. And so what you can see, this is me in the bottom right, and this is David here on the top, second from the left. And we're part of sort of the comprehensive team at the USC Spine Center. So obviously we treat spine patients. We have 6 surgeons, a combination of orthopedic surgeons and neurosurgeons. And we have 3 of the non-operative interventionalists who can take care of all the non-operative side of things. We do have a multidisciplinary approach. I think we all know that spine patients can be very complex. Some are simple, but some can be very complex. And when we treat them, we want to try to tailor the treatment to what their needs are. And so there's a whole lot of interventions and studies and tests that can be done before we even talk about surgical intervention. And to manage that, we've sort of assembled a comprehensive team. We have great relationships with our physical therapists, occupational therapists, our radiologists, psychologists, and our physician's assistants. Basically, we have a complete team. And we feel that everyone, even though everyone may have a very similar condition, they may have a herniated disc in their neck or in their low back, you really need to tailor the treatments because everyone's a little bit different. Everyone's expectations are a bit different. And everyone's needs are a little bit different, even if they have the same diagnosis. When it comes to surgery, we certainly feel like we have expertise in all the areas from cervical spine, lumbar spine, minimally invasive surgery, deformity, tumors, and trauma. But certainly on the interventional side, we have experts such as David who can do injections, they can do diagnostic tests and help us really kind of refine the diagnosis, doing EMGs and really kind of seeing all the problems that the patient has. When it comes to doing these procedures, we feel like we've been blessed because our institution has been very supportive as far as getting the latest and greatest technologies. I was recruited over to USC in 2013, and I can tell you when I was at UCLA, we were trying to get them to buy this very expensive machine down here you see in the far right. It's my understanding, I got a call from my colleagues, they just purchased that over at UCLA, which is great for them. When I got here, we have 3 of them here, and we have all these greatest technologies. So we really appreciate the support from the institution. We do have a mission. It's sort of a 3-pronged approach. We think that of the sort of the 3 prongs, one is multidisciplinary patient care. But number 2 is spine education for the next generation. We're big believers in education. And the third sort of pillar is innovative spine research. And so when it comes to our clinical patient care, we do have a lot of satellite facilities. We have 2 major hospitals where we do our procedures at. We have the Keck University Hospital downtown. We have the Verdugo Hills Hospital, which is sort of up in the La Cañada area. And that's where we do our primary elective surgeries. As far as our clinic centers, we have clinic locations throughout the Los Angeles area. We have a center in Arcadia, Beverly Hills, El Segundo, Garfield, Good Samaritan Hospital. Obviously, we're here in downtown Los Angeles at our major site. We also have a satellite in Pasadena, Ridgecrest, and also Verdugo Hills. We're obviously here for you if you have a patient where they need a second opinion or they need some treatments. We're happy to evaluate the patient and just give them our perspective on things. We're also educators, though. Our second pillar is education. We obviously have a pretty robust residency program, both in neurosurgery and orthopedic surgery. We have one of the top spine fellowships in the country. We have a medical spine fellowship, and we obviously have a number of medical students, international surgeons, and PhD researchers. We're also heavily involved on the international scene in education with a lot of the spine societies, both domestic and international. We also have a lot of relationships with a lot of international centers, and we've seen patients from all over the world. And we certainly do exchanges with education and research with many centers throughout the world. And then I think the last pillar is really the research. We have a very robust basic science and clinical research program. We have a lot of clinical trials ongoing, and we have a lot of collaborations with the Broad Center for Stem Cell Research, as well as the School of Engineering and the Comprehensive Cancer Center. And so in a nutshell, that's really kind of encompassing a little description for the USC Spine Center. We have this as a reminder to save the date. We do put on a yearly symposium, and who knows what will happen if we'll be able to travel, but we're certainly hoping we can go to Hawaii for an amazing educational conference in June of next year. So certainly we welcome anyone if they want to see sort of a comprehensive course on spine. With that, we'll get right into it. For those of you who may or may not know, if this is your first time here, or for anyone who's returning, we do have a monthly webinar series, and each month we touch on a different topic. Our topic today is going to be sort of focusing on the radiology of things, and I'm going to hand it over to David. He's going to talk about sort of imaging of the spine, and then I'm going to kind of give a surgical perspective. So I'll turn it over to David. We can see your slides, but you're muted.
What about now?
We can hear you now. Very good.
All right, great. Okay. Thanks, everybody. And thank you, Jeff, for that introduction. My name is David Cheng. For those of you who don't know me, I joined Keck early this year in January, and my primary specialty is in physical medicine and rehab, and with a subspecialty in pain medicine. Today, I'd like to talk to you about a practical approach to spine imaging. I have a few slides, so we'll just get started. I don't have any disclosures as relates to today's talk. I have three main objectives for today, and they are fairly straightforward. This is not a radiology tutorial. It's 20 minutes, and I want to hit on some big points. First is to review indications for imaging, compare the most commonly used imaging modalities at the Spine Center, and to discuss real-life applications. The target audience for today's talk is really all clinicians that treat patients with neck and low back pain, and this is inclusive of internists, family medicine doctors, physical therapists, as well as occupational medicine, and all clinicians are welcome. Patients that come to seek our services for neck and low back trouble, all evaluations begin with a history. And this is because context matters. In fact, for my practice, about 50% of the initial visit is dedicated to obtaining a focused history. I find that this is the single most influential factor to my decision making. As most patients with non-specific neck issues or back issues without red flags do not require any imaging. But we know that there are also limitations to history and also a physical exam. A focused history can provide valuable clues, but sometimes patients are not the best historian, or that the piece of history is non-specific, insufficient. And physical exam maneuvers can also vary in sensitivity, specificity, and inter-rater reliability. So this is why we're having today's talk, to talk about how diagnostic imaging can help with our decision-making process, and what goes through my mind when I am considering ordering some X-rays or MRIs. And clearly these are reserved for patients with kind of higher severity of pain, a more prolonged duration, as well as the presence of any red flags. And they can include neurologic symptoms, a history of malignancy, fractures, or infection. The guiding principle is that this radiographic study should influence management. And there are four primary reasons why I order imaging studies. First is to rule in a diagnosis. Second is to rule out kind of a diagnostic imperative, a diagnosis that's really bad. Third is that provides procedural planning. And this procedural planning applies for me, but also since I work with many surgical colleagues, one of my jobs is to anticipate the needs of my surgical partners as well. And lastly, and this is a big one, is to provide patients with reassurance and education. What I have pictured on the left side, this is published earlier this year by North American Spine Society. What you see is a diagnosis of and treatment of low back pain. These are guidelines intended to address many questions, and they include, with no red flags, what test is best for acute or chronic low back pain? Number two, which imaging findings correlate best with low back pain? What is the third, what is the association of spondylosis and low back pain? And which imaging findings help to guide treatment? Really the evidence is mixed or lacking to answer these questions. The takeaway here is that there's no single test that is the best for low back pain because it's a heterogeneous entity. It's a symptom that can come from a variety of problems, and so recommendation and evidence are completely dependent on the suspected diagnosis or clinical impression. The main radiographic studies that we'll discuss include X-rays, CT scan, MRI, and nuclear bone scan. I'm going to run through a few cases to illustrate these points. The very first case is a patient that presents with new onset neck pain after a motor vehicle accident. And the clinical suspicion here is fracture. So in the absence of any red flag symptoms, imaging may not be required for this patient. And this is also true for patients that have neck pain plus radicular symptoms. And when I say that, I mean primarily patients that have radicular pain and so without weakness or numbness. And this is because any imaging at our first line imaging generally is plain radiograph. Spondylotic changes are very common even in patients that do not have any symptoms. And so most cases of acute pain, defined as less than 6 weeks in duration, resolve. And what I have here is the Canadian C-spine rules. Obviously, this was initially named for clinicians that treat patients in the ER or urgent care. They're for alert patients with trauma and stable condition. But depending on where your practice setting, if you're the first responder, this may apply to you. You may also recall a similar set of rules, the Nexus low risk criteria, but this is considered a superior rules for diagnosing any cervical spine issues. And so if you're looking at the flowchart on the left side, there are essentially a few asks. Number one is, is the trauma a high risk or a high velocity trauma? And if the answer is an affirmative, then there is a recommendation for radiography. If the trauma is low risk, but there's midline tenderness to palpation, again, we would go ahead with some X-rays. And thirdly, if there's low risk, no tenderness, but the rotation, the cervical range of motion is severely limited, this is also an indication for radiographs. The four views that are commonly obtained are an AP view, lateral view from the side, open mouth view to see the C1 and C2 articulation, and lastly, a swimmer view to better visualize the C7-T1 junction. X-rays are widely accessible, and this is why it's the most common first-line test, useful for bony structures, as we know, poor evaluation of soft tissue structures, and certainly someone with a high velocity or high-risk injury, X-ray should be obtained without removing the C-collar. And if X-rays are negative, but the index of suspicion remains high, the CT scan is generally recommended as a second-line study, as this provides superior detail of the bony structures. This is an example of what you can find on an open mouth view. This is a C1 Jefferson fracture. You can see what is normal on the left side, the normal alignment between C1 and C2. And on the right side, you can see that there is displacement of the lateral masses away from the dens. And the typical mechanism for something like this is a diving injury, but clearly if you're in a very high velocity a car accident, this may also be a possibility. Essentially, the mechanism comes when there is axial loading of the axis of the cervical spine into the occipital condyles. We're going to move on to case 2. Case 2 involves a patient who is a smoker with a history of ACDF with persistent neck pain. Smokers, as we know, have twice the risk of experiencing a non-union. So the first line of studies that I would typically order is, again, X-rays to look for subsidence, non-union, and adjacent level disease. I have an example of that. So you can see that on the left side, this is a C5, C6 ACDF with a spacer on the left picture. And so on the right side, this is a radiograph obtained 10 months post-op, where you can see that spacer gradually sinking in to the superior end plate of C6. If you have any questions regarding surgical complications, kindly reserve them for Dr. Wang. And as I was saying, in terms of other things to look for bony abnormalities following ACDF, haloing is also a very important sign. And so essentially, this is pathognomonic for a non-union. You can see that on the X-ray picture on the left side. If the X-rays are normal, CT scan, such as the one obtained on the right side, shows us a C1, C2 transarticular screw fixation. You can see clearly there's some lucency or some spacing around that screw when it's supposed to be firmly affixed. And the decision for me in terms of whether to get the CT scan or whether to get the MRI after negative X-rays really depends on the chronicity of pain for patients after having undergone surgery. So for instance, if the patient has had a successful surgery and for many years the patient did fine, and then all of a sudden the pain occurred, my diagnostic approach would be very different than someone who had an initial problem, but the surgery never fixed that problem. Third, we are going to talk about an adolescent with subacute low back pain, where we suspect spondylolysis. Spondylolysis, of course, is an acquired fatigue fracture. It's pretty commonly seen, generally rated, can be seen about 5% of adult population. In elite athletes, that number can go up to 10, even 14%. And so the most common level to see this is at the L5 level. And what you're seeing here on the screen is an oblique X-ray of the L5 segments. And using this Scotty dog example, you can see that pars fracture represents the collar on that Scotty dog. In the very beginning of my practice, I order these X-rays fairly routinely, but as you'll see in subsequent slides, pars fractures can also be seen on lateral X-rays, and in an effort to reduce radiation, certainly with the oblique X-ray, we are increasing radiation field size, increasing that source of skin distance. I've largely gone away from the oblique X-rays. And another consideration is that for most patients that I'm imaging, these are younger patients, and the L5 level for these X-rays, we can't avoid kind of radiation to the reproductive organs, so I really don't get these X-rays anymore. These are lateral X-rays showing looks like a L4 pars fracture, and 7 years later, you can see that there is development of spondylolisthesis at that same level. And also the borders of that fracture looks different. And this allows us to assess, number one, for kind of interval change, but number two, it helps us, even if we just get one snapshot, to assess the acuity of this type of injury. For acute fracture, typically that fracture line is more narrow, the defect is more irregular, versus the picture on the right side. You can see that the borders are much smoother and they're rounded. For patients where even on a lateral X-ray, we don't see much flexion extension, radiographs can also be obtained to assess for instability. Next, we'll go to bone scan. Bone scan, you can see the picture is not quite as crisp. You can kind of see what's going on, that there's something going on the right side of the L5 level. It's meant to identify any metabolically active bony lesions. So it has a high sensitivity, but clearly the resolution is not so good. And identifying these diagnoses early, particularly in the young patients, an active lesion is important because, as you know, these type of fractures, when patients are immobilized, there's a high healing potential. The downside for ordering this test is that because it shows high or metabolically active lesion, it's non-specific, meaning that besides a stress reaction or a new stress fracture, there are lots of other things that can cause a positive bone scan. Obviously, the location of this is highly suspect, but infection, tumor, even arthritis can present as a positive test. A CT scan is considered the best test to visualize bony problems. And here, this is a CT scan of a patient that I've seen a few years ago, and you can see that pars fracture really well, right? And so the left side obviously is the sagittal view, and on the axial view, it's hard to miss. And of course, when we're seeing a fracture like this, where that fracture line is so clean, this is most likely has been there for some time, and we're seeing pars fractures. If it has been ongoing for this long, the likelihood of that healing on its own, even with immobilization, is very limited. Next, we'll talk about the gold standard for occult active spondylolysis, and that is a SPECT scan and a CT. So essentially, you get the best of both worlds. You get to see and identify the metabolically active lesion, as well as a bony detail that provides much better resolution. So what you're seeing on the left side is a fused SPECT CT scan that shows a fresh break. On the right side, you can see an old break denoted by that arrow. And on the other side, you can see that there's some sclerosis along the margins of that defect. So you can determine whether something is new or old. This is a very important slide because we're talking about X-rays, CT scans, and a SPECT scan, and it's particularly in patients in this demographic radiation matters, right? And this gives you an idea of when we say that there is increased radiation exposure, what does that exactly mean? If we're comparing,
Cheng, I'm so sorry to interrupt you.
Sure.
Your screen stopped sharing. We can only see you right now.
Really? So I am. Well, thank you for telling me.
I still see a screen.
Really?
Yeah.
I see you only, and I know someone else also said they can't.
Okay. So I'm going to stop screen and I'll share again. Does that sound okay?
Perfect. Yes. Thank you.
Sure, no problem. All right. Let me see if I can figure this out. Okay. Thanks for telling me.
Right.
It said the images are hard to see the screen switch. Is it possible that person viewing maybe changed the view from the speaker view to the slide view? So they changed the size rather than not being able to see?
Maybe, but now I can see it also.
Okay.
So we're good now. Yes.
All right. So you can hear me, you can see me, and the slide looks clear?
Yes.
Awesome. Perfect.
Thank
you. So what I was getting at here is that this gives you a relative idea about the amount of radiation dosage as compared to what it's like to be here in the world, well, maybe less in COVID times because we're getting out less. But so you can see that the L-spine X-ray essentially corresponds to 5 months of regular living, and SPECT scans corresponds to 1.5 years. CT scan essentially is equal to 3 years of US natural background radiation exposure. And certainly if we are ordering that previous test I was talking about with the SPECT plus CT, and that's both of those studies together. Recently, we see that MRI has shown to be similar in diagnosing active spondylolysis, and that's my second study of choice. So after an X-ray, my MRI is the second study that I get. And MRIs have a similar sensitivity as a bone scan, and compared to SPECT, it's able to identify about 80% of a pars lesion. This again is a previous patient that I've seen, and you can see that there are several advantages to MRI. There's no radiation, clearly. As opposed to a CT scan, it can also tell us whether there is an active lesion by the presence of T2 hyperintensity or increased stir signal. And even looking at the picture on the left side without an axial picture, you can see that the spinal canal, the AP diameter, is way bigger than the previous levels, and that's pathognomonic for isthmic spondylolisthesis versus degenerative spondylolisthesis, which is something that we see more commonly. The parasagittal cut can provide very valuable information. It's a picture on the right side. I really like showing this picture, particularly for patients to see. And you can see that for this gentleman, there is a significant amount of spondylolisthesis of that fifth level. You can see that it's sliding to the left compared to the bone below. And I'm going to use my cursor here. Hopefully you guys can see that. So what I'm saying is that the posterior margins of the L5 vertebra compared to S1, this is shifted to the left or anteriorly. And looking at the parasagittal cuts, I like to see kind of the extent of perineural fat surrounding the DRG and the spinal nerve roots. And clearly you can see that there is a big discrepancy between all the levels and the L5 level. You can also see some kind of modic type changes at the inferior end plates of L5. I am going to speed it up a tiny bit here. I have two last cases. The next case is a patient with a history of lumbar microdiscectomy with recurrent sciatica, and where we are suspecting either a new disc problem, a disc herniation, or post-surgical scarring. And MRI is really the study of choice. We're looking at soft tissue problems, particularly with disc injuries or nerve injuries. What you're seeing here is an MRI that's enhanced with contrast. And so this enhancement allows a distinction between a recurrent disc herniation and post-surgical scarring. As you know, intervertebral discs are largely avascular structures, and as such, with the administration of contrast, they really shouldn't enhance. So what you're seeing here, the middle picture is a picture T1 axial cut before contrast. In the picture on the right side, you can see the difference after contrast. This demonstrates the S1 nerve root to be surrounded by enhancing scar tissue. And for patients where MRI is contraindicated, but this continues to be a diagnostic problem, you can consider a CT scan with myelogram. Of course, this involves number one, the procedure, which is not that pleasant. And number two is the radiation with the CT scan, but nonetheless, it can provide us with similar types of information. The next example is it can present in a very similar fashion, and you can see again the picture before and after contrast on the left and right. First, I would identify the S1 nerve, and you can see that that's denoted by this big black arrow here. Then second, you can see identify the granulation tissue. You can see that all around here and over here, and you can see that lining up along the prior right laminectomy is also enhancing around that disc, recurrent disc herniation denoted by the D there. You can see that that lesion is not enhancing. So this is a valuable way for us to determine kind of the cause of a recurrent sciatica or S1 radiculitis for both of these patients. This is my last case, and this is a patient with MGUS and history of prostate cancer with diffuse back pain, where we're suspecting metastasis. Spine is the third most common site for metastasis, followed by following the lung and liver, and approximately 60 to 70% of patients with systemic cancer will have mets there. As we alluded to before, where MRI is really the study of choice, we're looking at soft tissue as well as bony involvement and even CSF involvement. And for this patient, MRI with and without contrast would really be the study of choice. But you can start off with a radiograph. And what I have here on the left side, this is the winking owl sign, where you can see the obliteration of the pedicle on the right side, or the left side. Left L1 pedicle. Of all the red flags or yellow flags that I think we've been taught when we're in school or in training, really the only red flag that's shown to increase the probability of finding cancer is a history of cancer. And so the reason that x-rays can be used as first line, but it's by no means definitive, is that it really requires a significant amount of bony disease for us to be able to pick it up on radiograph. In that the lesion, the size needs to be sizable, 1 centimeter in diameter, and there needs to be 50% bone loss for detection. So the false negative rate is 40%, which I'm sure everybody would agree is way too high when we're talking about cancer. This is an example of MRI with and without contrast, where we're seeing involvement subarachnoid nodules in the CSF. If you're having a hard time, you're needing to squint on the left side to identify those lesions, I am in the same boat. I think that it's not very easy to see, even with the MRI with contrast. It's not that easy, but certainly you can see that, these lesions are much more readily seen and visible on the right side. And so CSF enhancement is not common, but only when there is a huge kind of burden of disease where there's a massive tumor that's coating the surface of the CNS. A bone scan is useful if the disease is very diffuse, so it's invaluable for a full skeletal survey. The reason I mentioned MGUS in the very beginning is to make the comment that bone scan is helpful for a metabolically active lesion, and it's primarily for disease that is osteoblastic, and since that this is primarily a disease that activates osteoclasts, the bone scan sensitivity for multiple myeloma is low also. So, the MRI with and without contrast will really be our study of choice. And with that, I just want to conclude that we have 4 modalities that we discussed today. This is a very brief overview. X-rays would be the first study, a screening study, because it's so widely available. It can give us lots of important information, particularly when there's a bony problem or a previous surgery involving hardware. CT scan is the best study to look at bony details, especially if the initial X-rays are negative. Next to MRIs, or the study of choice for most patients with disc problems, nerve problems, because it allows us not only to see the bony problems, but it provides a much better resolution of nervous structures. And so this is particularly helpful for when there is a higher index of suspicion for infection and malignancy. Certainly when there is a focal T1 signal decrease where there is a replacement of bone marrow, we have to have a high suspicion for malignancy. And lastly, a bone scan is helpful for identifying metabolic lesions, but it's non-specific. I thank you so much for your time, and I'll turn it over to Dr. Wang.
Great, thanks, David. So I want to remind everyone that we're going to be taking questions through that Q&A. So if you look at the button at the bottom, if you ask a question, please type it in the Q&A. And what I'll do is I'll go ahead and give my talk, and then hopefully we'll have some time to answer some of those questions. But those are the questions we're going to answer. So let me share my screen, and David, give me a confirmation that you can see my screen before I start, and that you can hear me. We good?
I can see your screen. Yeah, sounds good to me.
So, I want to welcome everyone and thank you for coming. What I wanted to do is talk about spine radiology from a surgical point of view. And so in this aspect, I'm going to give you sort of what goes through a surgeon's mind. I think the vast majority of the people that are on this webinar are actually not surgeons. And so it gives you an idea of what goes through our mind when we look at these spine imaging studies. These are my disclosures. I do have royalties for products I've designed with companies. I have personal investments. I'm involved with many societies and many editorial boards. So it's interesting. When I see patients that come see me, they think they're special because they want to avoid surgery. And if they need surgery, they want the smallest minimally invasive surgery possible, and they want to avoid a fusion. The thing about it is that every patient I see wants to avoid surgery. And if they need surgery, they want the smallest, most minimally invasive surgery possible, and they want to be able to avoid a fusion. And actually, what surgeons would want, and this is my viewpoint when I see these patients, is that I want to try to avoid the surgery and get them treated non-operatively. But if they do need a surgery, we're always looking towards the smallest minimally invasive surgery possible, and we're also trying to avoid a fusion. And so the answer, the question we get a lot is, so when we have a definite pathology, why do sometimes we do fusions? Why do sometimes we not do fusions? And a lot of it depends on the radiology. And so what I want to talk about are three areas. I'm going to focus really on the first area, which is the radiology of the spine for surgical decision-making. And I'm really going to show you maybe one or two diagnoses, but you'll get the idea that for every diagnosis in spine that we're considering as spine surgery, we actually go through a similar sort of decision-making tree when we look at the imaging studies. And so I'm going to show you degenerative spondylolisthesis. This is one of the most common conditions that we see in our spine center. I'm sure a lot of you see this in your own practices. And you can see here, this patient has L4-5, where the posterior margins of the vertebral bodies, they're slipped a little bit. So this patient has spondylolisthesis. Now, we could just go to the literature. And these are two pretty well-known studies published in the New England Journal of Medicine that talk about whether or not to do a fusion or not to do a fusion. And so we could just go to the literature and say, for a patient with degenerative spondylolisthesis, the studies show we could do this or we should do that. The problem is everyone's different. And that's when we talk about this sort of personalized, sort of tailored treatment program. I don't think we can say that every patient with degenerative spondylolisthesis is the same. And so I want to show you how I look at it as a surgeon when we're thinking about doing surgery. So here's a patient with L4-5 spondylolisthesis. You can see that there's a spondylolisthesis at L4-5. You can see on the MRI, there's some degeneration of the disc, and there's some degeneration of the disc below it. And there is a little slippage of L4 on L5. Now, when I look at the MRIs, I'm not just looking at the slippage from the lateral plane, I'm looking at the facet joints. And so down in the lower segment, these are the more normal facet joints at L5-S1, and these are the facet joints at the area of the spondylolisthesis. You can see there's fluid in the facet joints, and you can imagine this patient lying down for the MRI, when they get up, they subluxate forward by about the amount of millimeters that you see in the facet joint. So this tells me that this patient is mobile, he's probably moving, and I'm more likely to think about doing a fusion for this patient. The other thing is that you look on the right side of the screen, we see the spondylolisthesis from a lateral view. Always look at the AP view. I'm always stressing to the residents and fellows that they need to look at the AP view. And what we see on the AP view is that not only do we see the spondylolisthesis from the lateral view, but on the AP view, we're seeing a coronal shift. So in two planes, looking at the lateral X-ray and the AP X-ray, this patient is shifted. And not only that, I can see, as you can see on the right side of the screen, these facet joints, this spine has been trying to lay down bone to stabilize this segment. So I see instability in two planes. I'm more likely to recommend a fusion for this patient rather than just a decompression alone. Here's another patient, L4-5 spondylolisthesis, and we see that basically we don't see the open facets. So we might sit there and say, this patient is a little bit more inherently stable than the last patient I showed you. And so this patient, we might be more inclined to do a decompression only without a fusion. The problem is we have to look at the orientation of the facet joints. If you can look at these facet joints, they're very vertical. And so they're vertical, they're not horizontal. And so when you look at this depiction here on the left side of the screen with the red arrows, these facet joints are very vertically oriented. So they're going to allow more motion in the anterior posterior plane and allow more slippage. If you look on the right side of the screen, these facet joints are more transversely oriented. So when I look at a patient with these more transversely oriented facet joints, I know that that's going to be a bit of a mechanical block. And so this patient is not going to be moving as much, and they have a little bit of a block to keep them from moving. And so here's an example. It's not always the same on both sides. If you look on the left of the screen, this patient has a very vertical facet here, but a very horizontal facet here. So if I have to decompress on this side is a little bit more stable. If I decompress this side and I do a medial facetectomy, which is undercutting this, I'm actually taking away the only transverse part of this facet joint, and I'm leaving it with a more vertical facet joint, which is going to be more likely to become unstable. So again, if I have to decompress this side, I might be more inclined to do a fusion, whereas on this side, it's a little bit more stable, and I might be more inclined to do just a decompression alone without a fusion. These are the two differences, right? So these are two patients, same diagnosis. So if you go back to those New England Journal of Medicine studies, degenerative spondylolisthesis at L4-5, but they're vastly different as far as the amount of instability that I think they have. Here's another patient, again, degenerative spondylolisthesis at L4-5. Now this patient not only has these open facet joints, as you can see, I'm trying to move the mouse cursor in a circle, but there's this big facet cyst. This tells me some of the compression is probably from the facet cyst, but also there's more disease in this facet. And with that diseased facet joint, it's going to be a little bit less stable, so I might be more inclined to do a fusion. However, we have to look at sort of the personality of the patient. This is another patient, degenerative spondylolisthesis at L4-5. But when I look at these x-rays, it's not moving a whole lot on the flexion extension x-rays, but there's definitely a little bit of movement. So the fact that it doesn't move that much, I might be more inclined to do a decompression only. But the other thing is, look at all these bridging osteophytes here. This patient is kind of a bone former. They're kind of more inherently stable when we look at these osteophytes here. And I just get a sense that this patient is a little bit more stable and less likely to become unstable. So I might consider doing a decompression only without a fusion on this patient. Here's two other patients, degenerative spondylolisthesis at L4-5 with a facet joint. Same diagnosis. And again, by the landmarks, they're totally different as far as the amount of instability. The patient on the left side of the screen, I'm more inclined to do a decompression only. The patient on the right side of the screen, same diagnosis. I'm more inclined to maybe consider a fusion. The other thing we have to add in are symptoms. And the symptoms are very important. And I'm going to go through the same scenario, but add in symptoms, and it's going to show you how it affects our surgical decision making. So say you have a patient with degenerative spondylolisthesis at L4-5, they have no back pain. If they have no back pain, I'm not so much worried that they're having back pain from the slippage because they have no back pain. If it's all neurological and I can get away with the decompression, I'm less likely to fuse this patient, okay? However, same x-rays, but say they have tremendous back pain. So even the people that do not want to do fusions would consider doing a fusion in this patient because you say, well, this patient has tremendous back pain. That back pain could be caused by that spondylolisthesis. So maybe I need to do a fusion to stop that subluxation to help with the patient's symptoms. Let's take a different scenario, same x-rays, no instability, no back pain. Even the people that do a lot of fusions for this condition, if there's no instability, no movement on flexion extension, just a standard stable slip, and they have no back pain, they'd probably be more inclined not to do a fusion, right? But what if they have no instability and you're more likely to do a decompression, but they have tremendous back pain? Then you're more likely to do a fusion just because you want to help with their symptoms. Same x-rays, no instability, no back pain, and they only have unilateral radicular pain. So I know as a surgeon, I'm not going to go in there and do a global decompression, which could cause more instability. They have unilateral radicular pain. I'm going to go to one side. This is a patient I'm more inclined not to do a fusion. I'm more inclined to do just a minimally invasive decompression. However, what if they have no instability, no back pain, and they have neurogenic claudication? This is even better. If they have no radiculopathy, but it's neurogenic claudication, then I only have to clear the central canal. I don't have to go out into the facet joints to risk more of creating more instability. So this is a patient that I'd be more likely not to fuse. So again, that gives you an idea of what the symptoms add to the radiology. The other thing is that even though the patients have the same diagnosis, L4-5 spondylolisthesis, I know what I need to do surgically. Okay, if I'm going to do neurogenic claudication, if I'm going to attack this spine in the bottom level, this patient has central stenosis and they have foraminal stenosis. But if they only have neurogenic claudication, all I have to do is clear the central canal. I'm more likely not to do a fusion because I only have to do a central decompression. I don't have to undercut the facet joints as much, which might cause more instability, which might lead me more to do a fusion. But what if you take the same patient and they have L5 radiculopathy only? And so you sit here and say, well, it's not really the spondylolisthesis. It's the traversing root. Now that's where it's very important, because if it's the L4 root, then it's not the traversing root, it's the exiting root. Now we all know when you have a spondylolisthesis at L4-5 and it slips forward, it pinches the foramen, which contains the L4 root. So if I have to decompress the L4 root here, then I'm more likely to do a fusion, because this patient has open facets, and when they slip, they're closing down that foramen. However, if it's not L4, but it's L5, then it's not the root in the foramen, it's the traversing root, so it's probably just the synovial cyst. I'm less likely to do a fusion, more likely just to take out the cyst, because that's really what's causing their symptoms. So again, same diagnosis, different management depending on the surgery and depending on the symptoms. What if you had L5 left-sided radiculopathy only, and you have these two pictures? Well, again, on the right side, there's open facets. We've said it's only the L5 nerve root, but this is slipping a lot. You're more inclined to do a fusion for the patient on the right. The patient on the left, it's the traversing root. There's a cyst there. The facets are closed. I'm more likely not to do a fusion on the patient on the left. What about neurogenic claudication only? Again, I talked about this. Don't have to undercut the facet joints. I only have to clear the facet joint. I have to clear the central canal, probably caused by that facet cyst. So I'm more inclined not to do a fusion and only do a decompression. Some case examples. This is how a surgeon looks at this. So I don't know how, David, you would look at this, but this is the things that I look at from a surgical perspective. I look at the spinal stimulator. I know this patient may be a chronic pain patient. I look at the wire, because if I have to do a surgery, I might displace that by just putting my retractors in there. I also look at the amount of pannus there. This patient is very obese, so it's going to be hard to do an anterior approach. It's going to be a lot easier to do a posterior approach if I have to do a surgery on this patient. This is an MRI of the cross section. This, again, going from the back, even though this patient's very obese in the front, I can still do a minimally invasive surgery from the back, because there's less tissue in the back than the front. So I'm more inclined to do a posterior approach. Now here's a patient that has compression in the lower cervical spine, but also some compression in the upper cervical spine. You can see this is C3-4, this is C5, this is 2, 3, 4, 5, 6, and this is C6-7, C7-T1. So this patient has myelopathy, but they have no neck pain. So even though there's a lot of arthritis in there, I was able to do a laminoplasty. So I didn't have to do a fusion. I went in the back, I did a laminoplasty, opened up the spinal canal. This is all this patient needed. They weren't having a lot of neck pain from the arthritis here, so I was able to forego a fusion. Here's a different patient, older patient, a lot of neck pain. There's compression of the spinal cord and bone on bone here at C5 to C7. And this patient had a lot of neck pain. So looking at the imaging, we ended up doing a fusion because this patient has neck pain and we wanted to help eliminate that symptom. Young patient has arthritis, but mainly has this disc herniation at C3-4, which is higher up in the cervical spine. Young patients, we want to try to avoid a fusion. Little bit of myelomalacia here. So you can see there's some cord signal change there. We did end up doing a disc arthroplasty. Young patient, good motion, didn't have a lot of neck pain. So again, in an older patient, this might not be a great surgery, but for this patient, did very well. This is a patient, I didn't do this surgery, came in, had this fusion. The plate seems a little off to the side. There's arthritis at the adjacent segments. This patient flexion extension, they have myelopathic symptoms. I showed this and one of my fellows was there and they were really focused on this myelomalacia here around where the previous surgery was. But I always say, don't ignore the occipital cervical junction. This patient is myelopathic from a cranial problem, a cranial cervical problem. There's pannus here. There's subluxation of C1, C2, and this patient has a lot of cord compression. And you can see here, this spinal cord is being compressed tremendously. So this patient needs a cranial cervical fusion with the decompression. Don't want to ignore the upper cervical spine. MRIs are great for showing contusions of the cord or any myelomalacia, as you can sort of see here. This is the one thing I always teach our residents and fellows. This, on MRIs, you cannot tell whether this is bone or disc. This CT scan shows that it's bone. So surgically, we can't be fooled by that because when there's that ossification of the posterior longitudinal ligament, like we see here, we can't assume that this is all disc material. If this ligament is ossified, there's absence of the dura. So if we go in the front, more likely to get CSF leaks. We usually try to treat these patients from the back. Here's a patient with a standard disc herniation. I always try to figure out, is it the exiting route through the foramen or is it the traversing route? Because it tells me what I need to do as far as a surgical decompression. If it's the traversing route, I need to get the traversing route decompressed here. If it's in the exiting route, then I need to clear the foramen. So from a surgical standpoint, we look at the imaging as far as what we need to sort of correct. Here's a patient I did recently, spondylolisthesis, degenerative disc disease at L5-S1, but had no back pain. So ended up doing just a minimally invasive decompression infusion because of the instability. He's doing great. Did not need to fuse this, even though it's more arthritic at this level and it's bone on bone, because back pain was not a big issue. And here's a patient that had a previous surgery at L5-S1 and now has stenosis at L4-5. It looks like there's big disc herniations there, right? MRI shows potentially big disc herniations, but it's actually bone. These are calcified discs. And so from a surgical standpoint, this is what I look at. I look at this patient had another surgery by another surgeon where they decompressed at L5-S1. Why didn't they get that disc out if it was just soft disc material here? It was still there. Well, the reason they didn't get it is because it was hard bone. You can't get that out. It's very difficult to get that out technically. The patient did well after the surgery and had the problem here. So we ended up decompressing it here. And again, couldn't clear out that calcified disc, but we were able to decompress it and the patient did well. But we start to look back and patients have had previous surgery. We want to know what they did, why they left things there. And so we look at imaging from a surgical standpoint from a completely different point of view. Scoliosis surgery, a lot of times these patients are osteoporotic. We have to do bigger surgeries in order to do a correction because we can't just put screws in from the back and torque on the spine. In the osteoporotic bone, they'll just rip out. So a lot of times we have to do these interbody fusions, such as what you see here, in order to get a good correction. And here's a patient where has stenosis of the foramen, previous 2 microdiscectomies done in an outside hospital, now has back pain and has foraminal stenosis. I can't just decompress this because it has foraminal stenosis and it's collapsed from the side. And so in order for you to clear this foramen, I need to jack this back out. So sometimes, even though the major problem is nerve compression in the foramen, we have to do a fusion in order to jack it back up in order to clear that foramen. You can't sometimes do just a decompression of the nerve root when it's collapsed down that much. And this is a patient that had a minimally invasive decompression at an outside hospital and it failed. Again, we talked earlier, everyone wants a minimally invasive surgery, but there are a couple reasons why this patient failed. First, they got some instability, right? When you look at the AP X-ray on the left side, those bones are shifted a little bit. You look on the right side, and L4-5 is a little suspicious for a spondylolisthesis, and sure enough, it moves just a little bit there. And so there's some stenosis that's going to be dynamic. When it slips, it's going to pinch against that nerve. And this patient had foraminal stenosis at L4-5. That's the major problem. And so what I'm trying to show you here is that they did a decompression at L4-5 with a minimally invasive approach, but it's very hard to clear these foramen with a minimally invasive approach. And that's where this patient's problems lie. And what I'm trying to show you here on the left side of the screen, these are open foramen, but here at L4-5, that foramen is collapsed down. So unfortunately, this patient needs a fusion, even though they tried to do a minimally invasive decompression, but sometimes the anatomy does not allow for that. And so with that, I'm kind of out of time, so I'm going to stop right there. But what I kind of wanted to do was give you a flavor of how we can't just say a patient with an L4-5 spondylolisthesis is the same as the other patient with an L4-5 spondylolisthesis. And when we sit there and then say we have to tailor each treatment plan as a team to the individual, I hope I've shown you kind of how we approach these patients, and we look at their unique anatomy, and some patients need different things. And I'm sure, David, you probably see these patients and they probably need different approaches for interventions and things like that. So with that, we are almost out of time. If there's any questions, I would welcome for people to certainly chime in and type questions. The thing I would ask for you, David, is that I think we have a lot of people that are seeing patients. Maybe it's the first touch point for patients with low back pain and maybe sciatica. At what point do you get x-rays? Do you get x-rays right off the bat? And what point do you get an MRI? Do you like treat them conservatively before you get the MRI, or kind of what's your sort of algorithm for that?
Yeah, I think it really depends on when I catch these patients. And at the Spine Center, naturally, patients that are referred to us, they more likely than not have had these symptoms for some time. And also the expectation is that they'll be seeing me or they'll be seeing you. And so if they haven't had any workup, AP lateral X-rays of the lumbar spine is what I typically start off with. Okay. And so in terms of the MRI findings, I think I don't typically order an MRI without neurologic deficits unless I am expecting that they are going to require some type of intervention, whether that be an injection therapy or potentially a surgical intervention. So to answer your question, I think for patients where the pain episode is shorter, where the pain episode is less debilitating, those are the type of patients that are more amenable to physical therapy and would do better with that. I don't talk about imaging. I'm sure you and I both have patients that really want imaging from the get-go, and so sometimes imaging is helpful to kind of I look at their expectations, their referring physicians' expectations as a factor also when I'm considering what type of test to get.
Yeah. The reason I ask you that is because, one of the things that I require when I see patients is that they have to have an MRI. And part of it is not because I just want everyone to have an MRI just to get the MRI, but it's like with only the X-rays, there's very little I can do, right? Sure. As a surgeon, I can't do surgery, obviously, without an MRI. The visit is probably 10 times as long because I have to talk about all the different possibilities. And I can't really order like injections because I don't think you can do an injection without getting an MRI to see the pathology, right? And so there's very little I can do without an MRI. And so that's kind of why I usually mandate that patients come in with an MRI, because part of it is I can't really do a lot with just the X-rays alone. So I guess my question to you is, you wouldn't do an intervention without an MRI, even if you've had like a perfect radiculopathy that goes in a certain dermatome and you're pretty sure that that's a nerve getting pinched. I don't think you would do an intervention without getting an MRI or some advanced imaging study. And then for you, when is an MRI too old?
These are really good questions. Number one is that, yes, I require or strongly prefer some type of advanced imaging, whether that be a CT scan or MRI. Sometimes for the patients that we see at Keck who have had CT scans or MRIs of the abdomen and pelvis, sometimes I cheat off of that, and if that allows us visualization of the area of interest, and I'm not concerned about a more proximal lesion, and the clinical diagnosis or picture is very clear. I don't think that a dedicated separate imaging is required. But yes, I think that in general, all interventions kind of prior to that, I want to be confident about my diagnosis before recommending any type of diagnostic or therapeutic interventions. Your second question about when is the MRI too old? This is a really tough question. I think that in my preparation for this talk, I came across a paper by Carl that said that 85% of patients with pre-existing or known pathology after with previous imaging and they presenting with the same thing, you order the new picture and essentially will show a similar finding. I think for me, it comes down to number one, are the symptoms similar or dramatically different? And number two, are there kind of these yellow or red flags that make me more cautious? And number three is the personality and temperament of the patient. Is this something that I would err more on the side of caution as someone that has been into the hospital multiple times the last year and they're just having really terrible luck? And I would much rather be kind of more vigilant about getting an updated imaging for that patient.
Yeah.
But I think in general, I think my cutoff is around two years or so.
Yeah. Yeah, I like to have a more recent MRI. I think, within a year or so is reasonable if you're just trying to do conservative care and their symptoms and they match up, right? When it comes to surgery, we like to have an MRI within 6 months. Just even if we don't expect a change, if we're going to go in and do surgery, we would just want to make sure something hasn't changed. We want like a recent picture. And I would even make that even a shorter period of time if they had an MRI within 6 months, but boy, they had some change in their symptoms, or I think there could be a change from that, or there's like new neurologic deficits or something like that. There is a question where it's when one of our things, one of our attendees is MRI is done on patients with osteoporosis routinely. Is it a sound policy? And I guess for my answer, and David, I'd like to hear your answer. For me, it depends on what you're looking for. I mean, obviously, if they have osteoporosis and you're worried about like a compression fracture or something like that, you know, X-rays may show that, but also sometimes you can see some early like bone contusions or some early fractures or some things that you can't really see, especially if they're very degenerative on X-rays. Sometimes you can't tell the chronicity of the fracture.
Yeah, so I think that I don't order MRIs routinely for my patients with osteoporosis. I think that really the type of patient that we're talking about is osteoporotic patient with back pain, right? And X-rays, as you mentioned, is a great first line test. The second thing that I would look for is, well, if I am suspecting that this is a very subtle bone contusion, like you said, or a compression fracture that is missed on X-ray, even if I find it on the MRI, what am I going to do about it, right? Is it severe enough to require vertebral augmentation? And if the pain is truly that bad, then yes, I would order an MRI for that patient. But I wouldn't say that for me, I would that is a routine thing.
Yeah. There's another question that says, how many millimeter shift on flexion extension radiographs of the lumbar spine is unstable?
This is one of my prior residents from Rush. So I will say that I think in my experience, my previous colleagues use 4 millimeters as a cutoff. I don't know what your criteria is, Jeff.
Well, so I guess it depends on what you mean by what you're looking for as far as unstable. I think what we look at is if you see a patient with a potential traumatic injury and you're seeing them in the emergency room, if you see more than 3 millimeters, you're worried there might be some acute thing that's causing that instability. But we see routinely people with spondylolisthesis that moves, at retrolisthesis or anterior listhesis that moves even more than that. I call that unstable. But when it comes to surgery, I think I've shown you some examples of patients with degenerative spondylolisthesis that have the slip, but we still wouldn't do a fusion on, right? So it's not just the amount of translation, it's when you get the flexion extension views, maybe that patient is shifted 3 millimeters, but when they bend forward and backwards, that 3 millimeters stays constant, it doesn't move. So that patient is relatively stable with a stable spondylolisthesis. On the other hand, if they're shifting forward, say they're 3 millimeters shifted, but when they bend forward, they shift 7 millimeters, then that patient's grossly unstable. I think most people do a fusion.
Yeah, I think that this question can be thought of in two ways. Number one is that are we seeing them in an acute traumatic scenario, or are we seeing someone who has chronic neck pain or back pain is progressing, and we're determining kind of what type of surgical intervention would be required? And I leave those X-rays to you because from my end, the fact that they have spondylolisthesis and facet arthrosis from the rehab or injection standpoint, it really doesn't change all that much. And if there are going to be film sets required, I'd much rather that they get them kind of closer to your evaluation. This way they're fresh.
Yeah. And so let's take the next question. And don't worry, we'll end it soon for everyone. So we don't want to keep everyone on too long, but there is one more question. What clinical symptoms alert you for imaging or referral to a spine specialist, example like paresthesias, motor loss, or pain? I'll go first, and then I'll turn it over to you, David, because I think I'm more talking about the thing that I like to alert people about is cervical myelopathy, because obviously, if anyone has motor loss or neurologic issues and there's some worrisome findings, you always want to maybe get some imaging just to be sure. But I think one thing that I see missed a lot is cervical myelopathy, because cervical myelopathy can be painless. I see 1 or 2 patients every month that come to me for low back problems. And during my exam, I pick up some findings that could represent upper motor neuron signs of cervical myelopathy. I get a neck MRI and they have very severe cervical like stenosis with myelomalacia, cord signal changes. And I start talking to them about surgery for the neck. And they look at me like I'm nuts, because I sit there and say, my neck doesn't hurt me. I came to see you for my back, but they have a really severe myelopathy. So it's it can be insidious on onset. You have to do a good neurologic exam. If they're hyperreflexic, they have Hoffman's reflexes, then I get a little bit concerned. If they're off balance, right? They're dropping things, or they're uncoordinated. Those are the patients I definitely would image and I would definitely refer. But I think, David, to you, the question was like, say you're seeing a routine patient, what are some of the red flags that would say this patient needs to see someone surgical more sooner rather than later?
Well, I think that if someone has severe pain or neurologic symptoms and the MRI matches up, and I think that this is eventually heading that way, in that the pain and disability is something that can be readily resolved with surgical intervention. And number two, clearly if there are kind of red flag or warning signs where I'm concerned about impending or permanent nerve injury, those are kind of the primary reasons I send patients for a surgical evaluation. Lastly, I just want to echo your point. I think I sent a patient to you a few months ago, a young patient who came in with some pain, but he was really kind of staggering. And I think the balance was a big problem. Hand clumsiness is a problem. And those are very important kind of signs to pick up for patients, even young patients. And so I think when in doubt, when treatment, kind of conservative care is not going as well as planned, I think that an evaluation to a spine center or a spine specialist like us may be appropriate.
Yeah, the only thing I would add to that is, for me, it's also pain out of proportion. You know, I've seen some patients where they have a little degeneration of their back and they're like on the floor in pain. And that gets me, where I've seen two patients with like dissecting aortic aneurysms that we caught in time. So pain out of proportion, and post-operatively, we use that. That's what I teach the resident fellows. If they have a post-op hematoma, even for their microsurgery, one of the hallmarks is just they have so much pain, it just seems out of proportion. Now, obviously, there could be some psychological things there, but if they're pain out of proportion, I get a little bit concerned. And just last, someone raised their hand and I unmuted. Marcos, did you want to say something or ask a question? Marcos Yang. Anyway, I'm still getting used to the Zoom. I saw that there was this thing called the hand up, and so I saw that you had left your hand up. But with that, I think we're out of time. We'll go ahead and conclude this webinar. Thank you all for coming. David and I really appreciate your attending. All of us at the USC Spine Center are here if you have any questions or want to refer any patients. And look out for our monthly webinar series. We'll send out an announcement for the next topic for next month. With that, we'll go ahead and conclude, and I hope everyone has a good night. Take care.